It's great to be here. I'm looking forward to sharing a sort of intro to chronic fatigue syndrome. So great that everyone's here. I'm going to, really in this webinar, it's an intro and it's laying the foundation for some webinars that we're going to do following up from this one. So this is going to kind of give you the overview and give you some practical tips about how to view the overall approach with chronic fatigue. But so we're going to jump straight in. I'm going to go straight to my slideshow here. So I'm also going to switch off the video. We might come back to that later. So I want to switch to my screen so you can see that. Here we go. So just to start with giving you the intro overview of what we're just going to cover in the hour today. We do need to talk about the diagnosis of chronic fatigue syndrome, ME, also known as myalgic encephalomyelitis. It is useful to understand how it's different from all these other illnesses out there and imbalances, because it's that fatigue is a very confusing term and it's a big problem in the science community as well. But then we're actually going to talk about, well, you know, okay, what is the diagnosis? How do you get there? How does it compare to other chronic complex illnesses? How importantly does that, why is that important for therapeutic and interventional purposes? Why is that important? But then we're actually going to go into maybe, you know, in some ways it's not that important, because we need to, when we get into looking at root causes, and I realised we got a little typo there, but just pretend we put ROOT, root causes. We need to look at we can ignore some of the sort of intricacies of diagnosis when we start to look at root causes. And the key things that I want to sort of portray in this webinar today is that you absolutely need a personalised medicine approach with chronic fatigue syndrome. If you came onto this webinar saying, hey, what's the protocol for chronic fatigue syndrome? The point is there is no protocol, because everybody is different. And we also need a kind of a levels of healing, a multidisciplinary approach. So I'm going to give you some sort of key takeaways. I've got some Q&As that I'm going to answer, and we've got a great offer and an opportunity to look into more of how you can use NESS with your patients with all kinds of illnesses, but specifically chronic fatigue as well. So just so that people understand, when we talk about chronic fatigue syndrome, it's also been known as myalgic encephalomyelitis. When you mention this, when we talk about adrenal fatigue, this wildly overused word, adrenal fatigue, depression, burnout, fibromyalgia and multiple chemical sensitivity, those two illnesses as well, there is no official biomarker for any of those illnesses, meaning there isn't a blood test, a serum test, or anything you can do to say, to get a diagnosis so your doctor goes, yeah, you have that illness. It's basically based on self-reported symptoms, and it's a diagnosis of exclusion. So basically your doctor checks for every other major illness, you know, that's related to these, that could be where there's fatigue present, and when nothing shows up and you seem to, well, you kind of seem to have fatigue, well, you've probably got chronic fatigue syndrome. So this is why, one of the reasons why it's been so confusing. You know, and one of the unfortunate things that's happened in the chronic fatigue syndrome community is that the official view really is that chronic fatigue syndrome is a form of depression. This is partly because we don't have the biomarker. What's essentially happened is it's got thrown into the sort of the psychiatric world. So unfortunately, the official treatments from, like in the UK, the NICE guidelines or the CDC guidelines here in the US, are things like the core treatments are graded exercise therapy, antidepressants, and cognitive behavioral therapy. These are extremely unpopular with patients, and obviously the implication of those kinds of interventions are, well, this isn't a biological illness, it's just kind of in your head, which has been very bad for chronic fatigue syndrome generally. And essentially chronic fatigue syndrome, as you're going to discover, CFS-ME, it's so in the middle of what we call the functional medicine model, where you get a whole load of marginal imbalances that in culmination can create a very severe imbalance. It really hasn't fitted into the conventional model. So in the Newtonian kind of conventional reductionistic model, I'm afraid, unless you have a structural anatomical abnormality, a serological abnormality, an infectious organism, a single physiological problem localized to a single organ, or a genetic inborn error of metabolism, if you don't qualify any of that, well, it's not real. Maybe it's in your head, it just belongs to the realm of psychiatry. So the whole kind of systems biology, functional medicine world, it's got totally missed because of this reductionistic medical model, not because the illness isn't very biologically real. And this has kind of, for many years, it caused all this trouble about maybe chronic fatigue syndrome isn't a real illness. Maybe just people are making it up, or they're doing it worse still, they're doing it for attention, or it was called yuppie fluid, and people have been treated very badly. But then there was a switch around because some major studies came out in the 1990s and found really that patients with CFS and ME are more functionally impaired than those suffering from type 2 diabetes, congestive heart failure, multiple sclerosis, and end-stage renal disease. So this is a serious illness. And if you've got patients coming in with this, it's a serious disease that you're dealing with, and don't underestimate it. 1998, as a result of these studies, the chief medical officer in the UK came forward after the reports came out and said, I recognise chronic fatigue syndrome is a real entity. Its distressing, debilitating affects a very large number of people, and it poses a significant challenge to the medical profession. Very true. The costs are huge. The losses of people not able to work, and the cost of people caring for people for chronic fatigue, anywhere between 19 to 24 billion in the USA, which is horrendous, and it's about a fifth of that in the UK, because obviously the population is about a fifth as well. So it's a big deal. Now, one of the problems we've had with an issue around diagnosis and the difficulty of just understanding the underlying causes, because if we don't have a clear diagnosis, it becomes very confusing. So the most used criteria that medical doctors are using to diagnose chronic fatigue syndrome is what's called the 1994 Fukuda definition. And this is the paper. You have to have 6 months or more of chronic fatigue, consecutive months, not due to ongoing exertion, not relieved by rest, not due to other medical conditions, and which significantly interferes with daily work activities and work. And then here's the key thing, and this has caused so much trouble and confusion in the industry, and has caused so much misdiagnosis. Basically, you have to have any of the 4 of these 8 symptoms, any 4. Post-exertional malaise lasting more than 24 hours. That's after any kind of exertion, that's physical, mental, or emotional. Unrefreshing sleep, significant brain function problems, muscle pain, pain in the joints without swelling or redness, headaches, tender lymph nodes, and a sore throat. Now, if you had any 4 of those, and those other criteria, that would be the diagnosis. Now, the problem is with that, if you look at those words that I've highlighted here in red, unfortunately, they are also overlapping with major depression, which is a psychiatric illness, defined with certain symptoms, including all of those. So essentially what you've got at the moment, the issues that we've had, is that when we sort of build a cohort, a sample size, where we're supposed to be studying chronic fatigue syndrome, as many as half of the people in our group could have major depression and not have chronic fatigue syndrome, because they're qualified, because the 2 are overlapping. So what we really wanted to do is start to define the chronic fatigue syndrome and depression. Are they the same thing or not? Okay, so this has been the challenge. It's dramatically impacted the prevalence. So if you use a tight definition and you say chronic fatigue syndrome and exclude everybody with depression, shall I explain how you do that in a second? You've got about 250,000 people in the UK who are purported to have chronic fatigue syndrome. In the US, depending on the criteria, it's probably 1 to 2 million, but it's as high as 4 million if you include all the people who have depression. So this is very difficult, and 1 to 4 million Americans who have CFS, less than 20% have been diagnosed, partly because of all these issues around it. Is the illness real or not? No biomarker, and the confusion that's out there generally. So what's happened is that there's been some really good researchers, biochemistry, biological-based researchers, who come together and said, let's get this definition clear enough so we know it's different from depression. And this started based on the Canadian consensus criteria for chronic fatigue, where they got together, an international consensus criteria got together, used the Canadian criteria and said, okay, this was a major panel, 400 years of clinical and teaching experience, authored over 100 peer-reviewed papers and approximately 50,000 hours of working with ME patients. You can see the list of all the people that were involved, Dr. Demolier, Dr. Klimas, and so on, so people who are well known in the CFS community as researchers. They got together, took the Canadian consensus criteria and said, the cardinal symptom that must be present for chronic fatigue syndrome diagnosis to be given is post-exertional fatigue. They called it post-exertional neuroimmune exhaustion. If there's one thing you take away from today, it would be this idea that a patient will do activity, physical, mental, or emotional, will either crash straight away or will have delayed fatigue 2 to 3 days later. Post-exertional fatigue. So that is not present in people with major depression. It is present in people with chronic fatigue, and it has a biological basis as well as a psychological. It's psychobiological. So following on from that paper, in the Institute of Medicine just in last year, 2015, brought out a large report. A top-class committee reviewed 9,000 scientific papers and noted it was terribly confusing. 20 different diagnostic criteria existed, and the CFS name is misleading. It trivializes the disease, and also there isn't enough data to actually back up ME, which was myalgic encephalomyelitis. That actually means brain inflammation. There are some papers showing that, but it's not representative of really what the full illness is. So they came up with a new diagnostic criteria, renamed the illness. Sorry, let's go back. They renamed the illness Systemic Exertion Intolerance Disease, SEID. Not perfect, but at least it's making it more seriously, taken more seriously by doctors, and is differentiating with depression. So this is still a self-reported thing. The diagnosis is still by exclusion, but here's the new diagnostic criteria. The same criteria, reduction or impairment in ability to engage in pre-illness levels of occupational, educational, social, or personal activities, has to last 6 months or more. Often profound fatigue, new or definite onset, can't be lifelong, is not a result of ongoing excessive exertion, is not substantially alleviated by rest. So you have to have all of that, and post-exertional malaise is a requirement, and you have to have unrefreshing sleep. Those 3 things. If you don't have any one of those, you don't have chronic fatigue syndrome. And they've put here that you also have to have one of the following 2 items as well: cognitive impairment or orthostatic intolerance. This is a great improvement. This will slowly start filtering out into all doctors' offices, and anybody who's now saying that illness is not real is really, that's very lack of education, and it's actually malpractice to start saying that kind of thing. So this is an amazing doctor. Dr. Leonard Jason is Professor of Psychology at the Center of Community Research at DePaul University. Essentially, he's the world-leading expert in the case definition of chronic fatigue. I had him on my large summit that Tamara mentioned at the beginning. Written many papers, been on major boards, has access to a huge community for research purposes in Chicago. And the reason I'm talking about him is that he has a brilliant, sort of easy way of defining the difference between depression and chronic fatigue syndrome. So if you ask a simple question to both groups, based on his research, this is what people would say: what would you like to do with your life? If you ask a depressed person, they say, I don't know, because the overawing thing is a form of apathy. If you ask a chronic fatigue person, they'll say, in response to what would you like to do with your life, they say a whole load of things, that just their body doesn't work. So this is very different than depression. So salient symptoms of depression not present in chronic fatigue: it's low mood, feelings of guilt, low self-esteem, and apathy. Those things there may be a comorbid, that means that, a chronic fatigue person can have depression as well, but not all of them do. The salient thing for chronic fatigue is post-exertional fatigue, which is, you'll often hear patients say, oh my God, I went out for the day, I went for a long walk, and the next day, or when I got home, or 2 days later, it was just like somebody pulled the plug. And it can lead to people being bedbound, housebound for days, hours, days, or weeks. And this is very important, and I want to get the message out there as much as I can about what chronic fatigue syndrome is really about and what it's like to have it. This post-exertional malaise is most likely linked to mitochondrial dysfunction. This this little part, this is an organelle that exists in all the cells of our bodies, most of them. It's responsible for producing ATP, which is the sort of major biological currency of all sort of life as we know it on the planet. Without mitochondria, the world as we know it wouldn't be as we see it today. I'm not going to go into depth about the mechanisms and therapeutic interventions for this time. That's going to be in a follow-up webinar. We're going to have a superb webinar on this topic from a multifactorial perspective, looking at it from electromagnetics, looking at it from biochemistry, and even psychology. So Dr. Sarah Myhill's work in this area, she's a leading expert in the UK, that's a paper she's written, is foundational with very good stuff. And also a doctor called Dr. Kramer that we're going to touch on his work, is an expert in mitochondrial function over in Germany. So we'll go into more depth of that later. But I just wanted to say, like, that's mitochondrial function is the defining sort of mechanism to explain that post-exertional fatigue. How is mitochondrial malfunction and chronic fatigue syndrome different from adrenal fatigue? I hate the word fatigue, adrenal fatigue. It's a bad name. They don't use it in the scientific circles. It's suggesting that there's something wrong with the adrenal glands when often it's not a problem with the adrenal glands. It's a signaling issue coming from further up in the hypothalamic pituitary adrenal axis. It actually starts in the brain and then starts to impact the adrenal glands through the signaling process. But here's the key sort of, in clinical practice, many clinicians would say these are your most common symptoms of what we should really be calling HPA axis dysfunction. So it's all the kind of things like there is fatigue or exhaustion, salt cravings, sugar cravings, difficulty getting up in the morning, feeling wired but tired, agitated or overwhelmed, sleep disturbances, headaches, decreased sex drive, anxiety, depression, blurred vision. So there is some overlap with chronic fatigue syndrome. HPA axis dysfunction is often present in chronic fatigue syndrome, but it's a subset. So and it would be these symptoms in addition to post-exertional fatigue. So you can be fatigued and exhausted during the day, but not necessarily go for a long walk and you don't have that sudden pulling of the plug, which is mitochondrial related. So this does exist a lot. I think I have the paper here just showing that the HPA axis dysfunction is common. It's found in chronic fatigue. It's a functional imbalance. This is a key thing. A functional imbalance meaning conventional medicine doesn't recognize it as a disease state. It's a marginal imbalance. It's not Addison's disease. So Addison's disease is a form of autoimmunity, which is primary adrenal organ failure, where you're not producing any cortisol at all. HPA axis dysfunction is just low cortisol output, and that has been found with chronic fatigue syndrome. So we've already picked these two areas that are key, that are showing up that you would want to assess for and potentially treat with recommend things for with chronic fatigue syndrome. Interestingly, this paper also said they find HPA axis dysfunction in depression as well, but it's a different type of dysfunction. It's not the same. So, which is, by the way, just interesting that depression does have a biological basis as well, and that's the direction that all psychiatry is going into as well. But anyway, what's the difference between burnout, chronic fatigue syndrome, and adrenal fatigue? So just so you know, burnout's another quite commonly used word. Dr. Joan Borisenko wrote a great book on this topic, Fried, which you see here. Dr. Joan Borisenko is a brilliant psychoneuroimmunologist. She has 3 PhDs from Harvard. She's like the mother of psychoneuroimmunology. And she also has personal experience with burnout, so she wrote this great book. Burnout is not classified as a mental disorder in the DSM, which is the sort of Bible of psychiatric diagnosis. It is classified by the World Health Organization's medical classification system as a type of psychological stress. It predisposes people to depression, and I would add it probably predisposes people to chronic fatigue as well. So what is it? In scientific terms, it's defined by 3 principal components. It's emotional exhaustion, depersonalization, and diminished feelings of personal accomplishment. Unlike major depressive disorder, which pervades all aspects of a patient's life, burnout is a distinct work-related syndrome. Burnout is likely to occur in jobs that require extensive care of other people, and it's most commonly the most commonly used tool for assessing burnout is this 22-item Maslach burnout inventory, and that inventory is kind of checks for a combination of high scores for emotional exhaustion, depersonalization, which is lack of compassion basically, and a low score for personal accomplishment. So essentially, depression and burnout are not the same. People with burnout are more able to enjoy things. They don't kind of lose weight, have psychomotor skill problems, which is coordination issues, less suicidal, don't have so much trouble with waking up too early, which depressed people do. They have more trouble falling asleep. They would attribute indecisiveness and inactivity to fatigue rather than being depressed, and have more realistic feelings of guilt. So really, it's a bit of a hybrid. It's a milder version of sort of, it's HPA axis dysfunction with mild depression. But it's not chronic fatigue syndrome. But if many of the things that cause onset of burnout, with the right kind of genetics, unfortunately, somebody could go on and get full-blown chronic fatigue syndrome, which would not be a good thing. Pseudo-fatigue. What is pseudo-fatigue? Well, first of all, so I think I've made it pretty clear already, chronic fatigue syndrome is not just in people's head. It is profoundly impacted by psychology, but the mind and body are really one. What goes on in the mind is also going on in the body, so there is a fundamental biological basis for chronic fatigue syndrome, as actually there is for depression as well. But pseudo-fatigue is basically where there's been a misdiagnosis. So it's common, and it's often missed, and it's where somebody is wrongly diagnosed as chronic fatigue when they actually have another type of illness. Now, when doctors who are licensed to diagnose somebody with chronic fatigue, they should have ruled out cancer, autoimmune diseases, heart disease, liver disease, anemia, kidney disease, diabetes, and hypoglycemia. All of those illnesses have chronic fatigue as a side effect, if you like. It's you know, fatigue is the most commonly stated symptom in all medical records, and it's often hidden though in the records because it's a subset of people saying, well, I have cancer, but I have chronic fatigue syndrome. Well, I have chronic fatigue, not syndrome. So this is why it's the most commonly stated symptoms, because it's present in all those major illnesses as well. So this is a practical takeaway tip. If you are seeing a patient comes to see you and they have serious chronic fatigue and have not been to a GP for a diagnosis, it's really, you must send them to a GP. And I know this isn't a requirement in some sort of us practitioners who are nutritionists, but I think it should be. And I think you know, if you see somebody who's got pretty severe fatigue, haven't been to the GP, they could be missing something serious that you're not licensed to diagnose. So I think it's your duty to do that. It's not difficult. The clinic that I ran in the UK, every single patient, it was a prerequisite that they brought this set of blood tests with them. Now, these set of blood tests are standard bread and butter blood tests that GPs do all the time. They would do these tests as a workup of check for ruling out chronic fatigue syndrome. And one of the things that I would say, if you have a patient who's been ill, diagnosed with chronic fatigue or related illness for many years, and they come to you and haven't been to see a GP for years, I would also send them back to the GP to get these test results if they've not been for a year. The reason is that things can develop. I had a patient who hadn't been to see a GP for 8 years. She was very ill with chronic fatigue syndrome. I sent her back to the GP because everything tends to get put in the pot of, oh, it's just my chronic fatigue syndrome, when something else could have happened. And this particular woman had actually developed thyroid cancer and missed it all that time because she was like, oh, well, the GPs are no good for me, conventional medicine doesn't work for me. You should be working with GPs, really, and adults with any chronic complex illness should be seeing a GP once a year and just checking in for their own health and well-being. For those people who are biochemistry-focused practitioners who have training in that area, you can also get a copy of the results, just request a copy of them and do some functional blood chemistry analysis on those results. You can use those results and interpret them in a way that GPs don't. And you can start to see these marginal functional imbalances that the GPs would just ignore. So they can be a useful part of your overall picture that you're building about your patient. So how important is having the correct diagnosis and having this biomarker? It's useful because important for empathy with the patient. You'd really annoy a patient if you just tell them they're depressed, because they might say they're depressed because they have chronic fatigue syndrome. It's not the same. And you'll lose trust and empathy with the patient if you start talking about that they're just depressed. CBT, antidepressants, created exercise is very unpopular and not very effective. The double-blind placebo-controlled trials in some cases show only a 30% improvement in about 30% of the group, which is really poor. It's amazing that it's so marginal, and yet that's the official treatment protocol. It's useful to understand the diagnosis because it's telling us about mitochondrial dysfunction, and that has some implications for from a therapeutic perspective. Having that diagnosis is also a powerful factor in making people take the illness more seriously. And they're looking now at coming up with a biomarker based around mitochondrial function. One research group is. So the illnesses will be taken more seriously when there's a biomarker. Not useful. It's not 100% useful having a diagnosis, because unfortunately that's the same with any chronic complex illness. It doesn't actually tell us about the host of all the other underlying causes. So the patient didn't wake up one day with a broken mitochondria for no reason. So we're really not getting to the root cause just because we have the name. So even if a biomarker linked to mitochondrial dysfunction is found for CFSME, it still becomes like most other chronic complex illnesses, poorly understood, treated with drugs that purely suppress symptoms and cause additional illnesses as side effects. And really just, chronic complex illness today is not well looked after by conventional medicine. Conventional medicine is really great for acute illnesses, broken legs, short-term things, surgery when required. But for these long-term illnesses where people have them for 20 years and stuff like that, the drugs and this one-shot cure approach is just it's really failing the whole, the world, really. So here's something interesting, and this is the idea. It's just some really important foundational facts to understand about chronic complex illnesses today, and specifically chronic fatigue syndrome. If you have a look at these illnesses, depression, chronic fatigue, HbA axis dysfunction, fibromyalgia, multiple chemical sensitivity, and those other chronic complex illnesses like autoimmunity and heart disease, they share many symptoms: fatigue, muscle and joint pain, brain fog, poor sleep, headaches. Is it possible that there's some underlying cause which is linked in all of them? So an underlying cause which might cause mitochondrial dysfunction in chronic fatigue syndrome, or might lead to changes in neurotransmitters in depression, or might cause reactivity to chemicals, but it's the same root cause. Are they linked? Well, the answer is, as you're going to see, massively. So here's a fantastically interesting diagram. This is just the top sort of 15 or so illnesses, Medicare beneficiaries here in the US. So people who've received insurance payouts for illnesses. Here were the percentage of beneficiaries of the top 15 selected chronic conditions. This is 10. So now the thing is, if there's an underlying root cause link between all these, wouldn't we expect to see people with more than one illness, i.e. a comorbid condition or state? The answer is absolutely yes. Look at this, absolutely fascinating. So people with heart failure, look at the bottom, about 2% of people have heart failure and just that one condition. A whopping 55% of people with heart failure have 5 other conditions from that list. Depression, about 10% only have depression. But a whopping, I think it's about 35% have 5 other conditions if you have depression. So I hope that makes sense. You can see that clearly. The majority of people, if you get one major disease, you're going to get more than one, because the root causes are linked. Here's a paper from the Journal of the American Medical Association. The most common chronic condition experienced by adults is multi-morbidity, meaning multiple illnesses. The coexistence of multiple chronic diseases or conditions. In patients with coronary disease, for example, it is the sole condition in only 17% of their cases. Almost 3 in 4 individuals aged 65 and above have multiple chronic conditions, as do 1 in 4 adults younger than 65 who receive healthcare. Adults with multiple chronic conditions are the major users of healthcare services at all adult ages and account for more than 2/3 of healthcare spending. Chronic diseases are not mutually exclusive. So what was fascinating is we've spent all that time saying, oh my God, chronic fatigue syndrome is different than depression, and yet they've actually shared some root causes after all of that. So that's why I'm kind of saying it is useful to have the diagnosis, good reasons to have it, but also there's a point that comes where, quite frankly, conventional medicine is great at diagnosing and not great at dealing with root causes. So comorbidities among common inflammatory diseases, that's this diagram. Each spoke of this wheel represents a published study appearing in Medline which shows a significant statistical relationship between one disease and another. So you can click on one, and like arthritis is kind of strongly linked with cardiovascular disease, which is kind of linked with Alzheimer's and dementia. And this was an amazing paper, but I highly recommend reading that paper if you're interested in kind of systems biology and things like autoimmunity. what are the major comorbid conditions with chronic fatigue syndrome? So when somebody's diagnosed with chronic fatigue, what are the most common disorders they're also diagnosed with? Well, here's the major paper showing this. Between about 72 and 77% of people with chronic fatigue also have fibromyalgia, and actually would fit with that criteria. Between 52 and 59% have irritable bowel syndrome, as well as chronic fatigue. 13 to 24% have multiple chemical sensitivity. Interstitial cystitis is common. The other big ones are tension headaches, chronic low back pain, chronic pelvic pain. Coming up to like between 40 and 50% of all patients with chronic fatigue have these comorbid conditions as well. What's the implication? That the root causes are the same. Lyme disease, lots of confusion and overlap between Lyme disease and chronic fatigue syndrome. This is a paper showing that when you use not just Western blot to diagnose Lyme disease, but the expanded testing methods that many Lyme literate sort of alternative doctors are using, they're saying here they seem to fit a similar phenotype to chronic fatigue syndrome. I've had a lot of chronic fatigue syndrome patients who've probably been misdiagnosed with chronic fatigue, and actually they have Lyme. So, because they share so many symptoms, similar underlying causes. So what's also very interesting, how many people with chronic fatigue syndrome also have comorbid psychiatric disorders? A whopping 25% have current major depression. 25% of all chronic fatigue syndrome have also major depression, probably because they're ill and the same root causes are going on. 50 to 75% of patients have a lifetime history of major depression as well. Generalized anxiety disorder is high in chronic fatigue syndrome population, and anxiety disorder is a common preceding onset of chronic fatigue syndrome as well. So that's just muddied the waters, hasn't it? What are some of these underlying causes and mechanisms that are the root cause that are going on in everybody? Well, this is where we have to stop. We have to talk about inflammation and all the things which cause inflammation, which will be leading to all those different chronic complex illnesses. And this is, part of this movement in the functional medicine community that we're now understanding these commonalities. And inflammation was on the front cover of Time magazine. It's famous now. And this was a brilliant paper. It was actually looking at depression. So it's from Nature Publications. The paper's called Neuropsychopharmacology. And they're actually looking at the causes of depression, but they also said, so look at some of these causes. A leaky gut would cause inflammation, T-cell dysfunction causes inflammation, psychosocial stress, and early life stress. If you saw my presentation on adverse childhood events, I really recommend you look at that. Huge correlation with loads of different types of chronic complex illness onset in later life. What's the commonality? They all cause chronic inflammation. And so chronic inflammation is present in CVD, depression, cancer, diabetes, all of the other major illnesses, chronic fatigue syndrome. But, why does one person get depression, another person get cancer, another person kind of gets chronic fatigue syndrome? Probably just your genetic weak link. But the stresses can be the same. Now, the combination of stresses that are causing the inflammation can be different from each person. So somebody might have huge gluten sensitivity, develop loads of leaky gut, took all these drug medications for it, developed chronic inflammation, and then went on to get chronic fatigue syndrome. Someone else may have many adverse childhood events and are actually in a state of chronic emotional stress and anxiety, which they just can't switch off. And that will lead on to things like HPA axis dysfunction, mitochondrial dysfunction. So it's a different route in. The root causes are common, and throw in some of the genetics, and then you'll have your sort of the soup that makes up the your kind of illness. So this is why there's no fixed protocol for chronic fatigue syndrome, or these others either, when you want to deal with root causes. This is an even sort of more comprehensive, useful diagram from a peer-reviewed journal. Genes don't determine our health. We are impacted by epigenetics. So environmental factors change our bodies epigenetically to be pro or anti-inflammatory. So, look at the bottom. Exercise can have an anti-inflammatory impact. Too much exercise can be pro-inflammatory. The microbiome, a healthy microbiome is anti-inflammatory, and imbalance is pro-inflammatory. Many therapeutic drugs will be pro-inflammatory over the years. Some are anti-inflammatory with side effects. Alternative medicine, many treatments are anti-inflammatory. Psychological state, social interactions, huge studies showing that if you have poor relations with other people, you have increased signs of inflammation, biological inflammation. And psychoneuroimmunology is the science and the study of mind-body medicine, and there's loads of studies out there showing that stress increases inflammation, and it's working through the body epigenetically. It was nice to see they picked up seasonal correlations, circadian rhythms. Exposure to too much blue light at night is going to upset epigenetics and is pro-inflammatory. Not enough sunlight during the day is pro-inflammatory over the time. Exposure to germs obviously is pro-inflammatory, and these other things. So what illness you get depends on your genetics. What the root causes are for you will be different for each person. Will be some kind of combination usually of these types of things. This is when we start to address this is root causes, and what conventional medicine does is ignore all this and just you have a one-shot cure drug which usually just suppresses a symptom or blocks an enzyme and doesn't deal with the underlying causes. And it's no wonder that a lot of people are very unhappy with kind of the help that they get or are not getting just with pure conventional approaches. So the upshot is no one-size-fits-all treatment for chronic fatigue or any chronic complex illness today. This has led on to Dr. Jeffrey Bland, the father of the functional medicine movement, founder of the Institute for Functional Medicine. This is why he wrote his book called The Disease Delusion. So, he's getting to this point of saying, why are we spending so much time diagnosing? It doesn't tell us anything about the root cause, and really maybe this external expression of a particular disease we've called chronic fatigue syndrome or depression or whatever it is actually somewhat irrelevant, because it's a whole set of functional imbalances caused by environmental root causes. So the idea that, I hope I've explained this up to this point. So functional medicine principles really revolutionize medicine, because when you're moving away from you're treating a disease, you're now treating the person and their environment. Treat the person, not the disease. So this is the key thing you need to be thinking about with chronic fatigue syndrome. And I've got some case study examples based on real life patients that I've worked with or colleagues of mine, to show you just how different it can be. So one case study example is somebody who's recovered. She was a female, early 30s, diagnosed with chronic fatigue 10 years ago. She was a lifelong vegan. She had some level of eating disorder with that, highly sensitive type, so she was prone to being having problems with adverse childhood events. She had illness triggered by a trip to India where she picked up parasites. Her diet was extremely clean, organic, very little processed or refined foods. But she had severe B12, zinc, iodine, and iron deficiency, common in vegetarians. She had this NR3C1 single nucleotide polymorphism, which actually made her more sensitive to stress. So when a stressor came, her cortisol levels stayed higher for longer than the general population. She had very low protein levels, low stomach acid, wasn't digesting her food properly. She had mitochondrial dysfunction, adrenal fatigue or HPA axis dysfunction, and gut dysbiosis, bad gut dysbiosis, and a huge leaky gut. So what did she do? She did brain retraining course to reset the stress levels that had programmed in psychologically and into her brain using neurolinguistic programming. She stopped being vegetarian. She supplemented stomach acid, protein, minerals, all the nutrients that she'd missed out on. She was treated nutritionally for mitochondrial and adrenal imbalance, nutritionally treated to sort out the gut and the leaky gut. She started earthing, which is connecting barefoot to the earth using electromagnetic balancing recommendations. She'd learned to pace. You cannot recover from chronic fatigue syndrome if you're not pacing properly, because it doesn't give the time to the mitochondria to heal properly. Big improvements over 2 years. Finally completed something called network spinal analysis, which is an energetic treatment that works on energetic imbalances and blocked emotions. That was the clincher for her. She finally recovered due to, we think, probably because she was resetting the vagus nerve at the energetic level. So just look at this. That's she was using a multifactorial approach. Psychology wasn't enough, biochemistry wasn't enough, and energy medicine on its own wasn't enough. It was a multidisciplinary approach required. Here's another example. It's an 18-year-old girl, 4 years diagnosed with chronic fatigue, fairly good childhood, some early life stress, 16 years of steroid medications because she had asthma and eczema. Exam stress triggered the CFS. She had gut dysbiosis, candida, and inflammation. We discovered she was dairy intolerant, which is why she had asthma and eczema. If she'd known about the dairy intolerance, she would never have needed 16 years of steroid medication and therefore wouldn't have got all the leaky gut and the gut problems that came from the steroid medication. Her adrenals were actually not that bad. This is an interesting one. She was so we put her on an anti-candida diet, no dairy, gluten for 10 months, treated for gut dysbiosis using nutritional probiotics, had calming amino acids, a little bit of mitochondrial support to reboot that, and recovered within about a year. It was about 10 months. Went travelling, went to uni, got on with her life. So that was somebody who just needed a biochemical approach. Doesn't work for everybody. Two more examples. 32-year-old police detective suffered post-traumatic stress disorder after years of traumatic service in the worst area of the police in the UK. His diet was terrible. Diagnosed with chronic fatigue. Completed the neuro-linguistic programming course to clear and reset the emotional trauma and the anxiety that had been programmed into the neurons in the brain. So he was programming his body into a healing state. He forced himself to learn pacing. Very difficult to just slow down and understand you couldn't just start running marathons, and pacing activity levels, very, very important in chronic fatigue syndrome recovery. A major diet cleanup, which may primarily involve balancing blood sugar. We were just doing the basics like switching to organic, no refined sugar, add vegetable juicing and vegetables, just, just vegetables, kind of protein at each meal. He was doing green drinks, probiotics. Recovered, for him it was about a year or two, it took about a year or two. And here's a final example. So just to say with that previous one, that was psychology was very important, and psychology and biochemistry. Here's another example. 20-year-old was diagnosed with CFS after a bit of a hedonistic uni life, bit of alcohol, bit of drugs. CFS triggered when they dealt with social family stress, coming out as gay with the family. Spent 4 years bedbound, six years housebound, severe adrenal dysfunction, gut and back pain, major gluten, soy intolerant. Moved to, for many years, was on a very clean, unprocessed and unrefined diet, years on that kind of diet. Undertook all types of naturopathic detoxification, Gerson therapy, coffee, work on the psychology side, was reading a lot in that area, but the thing that clinched it for him is which I'll touch on later. They're a sort of homeopathy, but not. And it was the energetic information lesson which finally brought him back recovered over an 18-month period after 6 years of illness. So again, totally different. Here's somebody who mainly did diet and energy work and recovered. So it's different in each case. Protocols need to be personalised. Maybe a combination of biochemical, psychological, behavioural or energetic intervention, multidisciplinary approach required. I'll talk more about this later. You don't need to train in all modalities, but your awareness counts. Your awareness about how these other modalities work and how your modality fits in with the other ones is important, and it's important to have a referral network that you can rely on. So this is a comparison. It's just an easy comparison of systems biology, if you like, functional medicine versus this Newtonian kind of conventional medicine model. Systems models understand and recognise as a personalised multifactorial medicine approach, whereas the conventional model is one size fits all. You're given a diagnosis of an illness and you get one thing for that illness. Everyone with cancer gets this thing. Everyone with diabetes gets that treatment. Everyone with chronic fatigue gets that one treatment. One size doesn't fit all. I think I've demonstrated that. Recognition that disease and health exists on a continuum is very important. We don't suddenly have a broken mitochondria or an underfunctioning adrenal system one day that's just that one isolated piece of the body that doesn't work anymore, and all you need to do is have that piece replaced. No, that's how the conventional model sort of sees the body as atomistic. It's either you have a disease state or nothing, and it's one part that breaks that you have to replace. No, in a disease on a continuum means everything affects everything else in the body, and you can have marginal inefficiencies and imbalances that overall can cause major dysfunction. And that's why it's an open system. Everything affects everything else. That the brain and the body are connected. How you think and feel emotionally affects you biologically. It's still not really accepted in mainstream conventional, medicine. It's getting there very slowly. We are striving for optimal functional balance. The conventional models treats the disease, not the person. Functional medicine and systems body treats the person, not the disease, and germ theory of disease is very prevalent in the conventional medicine models as well. So your cause of an illness is some external bug, and that was very effective a couple of hundred years ago when we had a lot of germs that we learnt to use antibiotics against and vaccines and things like that. Unfortunately, that's not how most chronic complex illnesses are now working. They're not caused by one bug. And if you have infections or opportunistic multiple infections, it's usually because those other factors have changed the strength of your body, so your immune system's not working to get rid of the bugs anymore. So it's things like emotional stress, poor diet, all of those factors causes the immune system to underfunction, and then you develop infections. So complex adaptive systems, everything affects everything else. They have feedback loops. You see this all the time in chronic fatigue. Someone has emotional stress from childhood, that causes gut dysbiosis and leaky gut, and they're not detoxifying properly. The toxins in the gut dysbiosis then causes more emotional stress, and then we have a vicious cycle. And these are feedback mechanisms. So this kind of network analysis is what we need. And this also means that one of the things you're going to need to be aware about with patients is that often you hit a tipping point. So the whole system can change all in one go very quickly and reorganize itself to a lesser functioning state. That's often when a trigger happens and the whole system kind of collapses into a disease state. When you're improving and you're taking, if you like, the weights off the boat and you're improving your environment and lifestyle changes, what can happen is a tipping point where you get improvement all at once, and it takes it can take a couple of years sometimes to actually hit that tipping point. It takes a lot of trust and a lot of engagement and compliance from your patient, and expectation management. So very important to know that sometimes people can be doing huge amounts and not actually see anything for sometimes months. So that's going to be part of your, keeping your patients on board with you, is that you can explain this model and the expected timelines. It's not like a drug that just fixes you with you in a few days. This is just an example of this disease health continuum I'm talking about. Addison's disease is a diagnosed disease state. Adrenal fatigue is in between, but it's not optimum either. Heart disease, well, is obviously a diagnosed disease state. In chronic fatigue, you have this left ventricular dysfunction that's been found. It's not a diagnosable disease state, it's not heart disease, but it's not optimum either. And you have that same in the immunity, the gut, and so on. So what's very interesting is that here is a paper by one of the pioneers in chronic fatigue syndrome, Jacob Teitelbaum, who wrote From Fatigue to Fantastic. He's a New York Times, probably the best-selling author in the chronic fatigue syndrome space. Wrote this paper, got it published in the Journal of Chronic Fatigue Syndrome all the way back in 2001. A randomized, double-blind, placebo-controlled trial. Over 80% of patients in the study made a significant improvement in 3 months. 72 patients in the placebo-controlled trial. He believes, he's got a theory about that we're going to go into in the next CFS webinar about hypothalamic suppression due to stressors, which is he's probably bang on with that. So this was his intervention, multifactorial. So if someone had subclinical low thyroid, low adrenals, subclinical, no, not Addison's disease, not diagnosed thyroiditis, Hashimoto's, but subclinical, not optimal, but not a disease state either. Dealt with nutritional deficiencies, postural hypertension, sleep disorder, opportunistic infections. Interestingly, he was only using biochemistry, but using a multifactorial system approach, using both drug and natural interventions. So got great results. And here's what he says. There are times that an illness occurs as a cascading series of events where each dysfunction may trigger several others. Some physicians may be uncomfortable with the study that one uses multiple interventions adjusted for each patient, i.e. personalized, and two that treats patients based on symptoms despite lab values being within the normal range. It is helpful to remember that this bias comes from having been trained in a period when a reductionistic approach was fashionable, and not because this approach holds any greater scientific validity. Why then would one treat for a process if the blood test is quote-unquote normal? Unlike primary organ failure, where the deficits eventually become marked alterations in the patient's regulatory system, alterations in the patient's regulatory system can cause multiple marginal deficiencies, which in aggregate may cause severe dysfunction. So it's that disease continuum thing in expression there. So my final sort of takeaway from this, we talked about systems biology, you know, there's also sort of, if you like, more than one body to consider that's at the root cause. When we're talking about root causes, there's root causes at the biochemistry level, there's root causes at the energetic level, and there's root causes in the psychological and spiritual levels as well. This happens to be a model that Dr. Dietrich Klinghardt, a huge sort of a man I'm a big fan of, uses in his practice, for example. And, you know, the sort of root causes, imbalances, and treatment interventions you'll want to consider being aware of. Some people out there are trained in more than one modality. That's great. If you're not, it doesn't matter. You just need to be aware of how important these other root causes can be, and that you have a network of referral people. You know, when your stuff isn't working or the patient's not getting what they need, it's part of your referral, part of your service can be having a good referral network, so the patient will actually trust you more than ever because they know you're not just trying to force them to do something which is a one-shot cure again, that actually is not, you know, maybe what they need. So at the physical level, you know, in chronic fatigue syndrome, it's going to be things like mitochondrial dysfunction you're going to be assessing for, redox balances, free radical stress, adrenal, thyroid, endocrine imbalances, detoxification issues. We're going to go into all of this in future seminars or webinars. Opportunistic infections, single nucleotide polymorphisms, SNPs like MTHFR, NR3C1. It's also metabolic imbalances like porphyria and pyroluria, nutrient deficiencies, amalgam silicon plants. So it's just think that's everything at the biochemistry level. Interventions would be drugs, herbal, dietary supplements, diet, chiropractic, osteopathy, surgery, dentistry, physical lab testing, exercise pacing, colonics, massage. You kind of get the message. What are we looking at the energetic level? If the information is out of balance and the energy is blocked, what are the sort of things that we're looking at? Energetic blockages and meridian disruptions, micronutrient therapies would be interventions at this level. Some of the most important interventions that you can recommend are at this level. Yoga, Tai Chi, and Qigong are, you know, have research behind them, can be profoundly helpful for chronic fatigue patients. Earthing, sunlight, circadian rhythms, bioresonance, structured water magnets, heat and cold. You know, cold thermogenesis has been found to stimulate the vagus nerve. You know, so very important things at this level. Other hugely important things at the psychological level, you know, somebody's beliefs, their attitudes. Think about the placebo effect. If you have a maladaptive stress response, it's a huge factor in chronic fatigue. If somebody's chronically stuck in a state of anxiety, they're anxious about their illness, they have unresolved emotional trauma, you just have to have seen my ACEs webinar, my Adverse Childhood Events webinar, to know that emotional trauma has a dramatic impact on all chronic complex illnesses. Things you'd be looking at this level would be like NLP, EFT, CBT, EMDRs, eye movement desensitization and reprocessing, psychotherapy, hypnosis, meditation, huge one. Meditation reduces inflammation, and that's scientifically shown. Neurofeedback, homeopathy and infoceuticals would actually work at the emotional, mental level, coaching and counseling, obviously. The kind of top two levels, I put in they're called spiritual, but it really comes down to kind of meaning. So if your patient doesn't have a good meaning of why they should recover, why did this illness happen to them? It's a bit along the lines of the hero's journey, of Joseph Campbell's hero's journey. For people to recover, they need a good reason, and they need some feeling about how they're going to, you know, how does anyone have resilience when terrible things happen to them? Their life could have collapsed, they lost their job, the marriage often breaks up when you have serious chronic complex illness. So if they don't have a good reason to recover and have created some kind of meaning, if they need to move out of existential grief and into meaning and purpose, and they might need to change who they are at the identity level, but this can be one of the defining sort of reasons that somebody recovers or not. So, you know, and science cannot speak to meaning. Science has not given the world meaning for why anything happens. It explains the hows, but not the whys. So I could go into Ken Wilber and 20 books that he's written about philosophy and sort of theories of everything on that. Too much, bit beyond this webinar, but we will actually come back to that kind of thing. Humans don't exist in a vacuum, so each body, if you like, has environmental impacts. So what are the environmental factors affecting the physical body? Pesticides, chemicals, GM foods, mineral depletion, soil, poor social support, access to finances, internet, access to information on the internet, time in nature, urban living. You know, our environment is hugely important. Same with the energy level, all the Wi-Fi, the mobile phones, the electromagnetics, off-gassing, lack of earthing, lack of sunlight. The environment's very important. Hugely important at the mental level is your relationships. Huge studies showing that people, 300,000 people level studies showing that if you have poor relationships with other people, I call the people who are kind of stealing your energy vampires. These people will keep you sick and increase inflammation, and suppressive cultural values and beliefs like chronic fatigue syndrome, ME, is not real. You know, cultural beliefs that are not true like that have incredibly negative impact on people's ability to recover. Mass consciousness and some of the terrible stuff we see going out in the world. You need to learn how to do a relationship detox, boundary awareness, support groups, ability to communicate. At the high level, you know, relationship with something bigger than yourself. You know, it might be faith, it might be spirituality, it might be soul. There's also your ancestral family lineage, which comes into this level as well, because trauma is intergenerationally inherited. That's something that we covered in the Adverse Childhood Event webinar. So, just keeping an eye on the time here, we've got five so more minutes. The evolution of medicine, you know, I just thought this was a cool little map of reality. You know, if your map of reality is limited, you lack wisdom. So the knowledge one there in that little picture is kind of where conventional medicine is, and they have a few insights about, oh, we think, you know, there's mitochondrial dysfunction. They see one piece of insight, but what about the connections between things? So that's having a wider map of reality, and we need this wider map with our patients. You know, you're not actually a holistic practitioner if all you're doing is biochemistry. You're not a holistic practitioner if all you're doing is energy medicine. But if you're building awareness about how these other interventions work, and you know when to refer, or you start to develop a bit of a multidisciplinary capability, this is good, and you're going to be more holistic. Why has the outdated model lasted so long? I'm afraid it is because it totally is. The big pharma needs an atomistic, Newtonian, one-shot cure approach to justify drugs. So thought I'd just mention that. Probably most people realise that by now. Keys to take away. Correct diagnosis is useful but says little about most of the underlying causes. You want to optimise biochemical, energetic and psychological environment. Don't focus on treating the disease. There is no one-size-fits-all approach for fatigue. It needs to be personalised. Multifactorial is always better. And avoid fixation on one type of healing. You don't have to train in all modalities. It's your overall awareness that counts, the overall map that you're using. So this